second of a weekly series of Zoom meetings of IAP Thiruvananthapuram. It is actually, the idea was put forward by our own President Bennett sir, and we are just executing it. Today it's the newborn notes, and our idea is basically these talks are mainly to suit the basic doctor. It could be a pediatrician, but it is for the basic, all the basic practical tips. And we have eminent speakers with us from 5 different hospitals. I welcome all the speakers, the moderator, and I also welcome all the delegates who are all the participants in this meeting. And Anju, over to you.
Okay. Thank you, Dr. Priya. Now we have the first talk, Newborn and COVID, by Dr. Radhika, who's the Associate Professor of Neonatology, SATH Hospital, Trivandrum. Dr. Radhika.
Thank you. Thank you once again, Bennett sir and Priya and IAP Trivandrum for giving me this opportunity. I'll be once again speaking about how our neonates are affected and how they are managed during these COVID-19 infection. We know that having an immature immune system, they are vulnerable to serious bacterial and viral infections. And there is a lot of concern how this COVID season may affect them. The effect on the fetus, currently, there is no data which suggests an increased risk of intrapartum or vertical transmission, thankfully. And there are few case reports of neonatal babies being affected by the COVID-19 infection. Any pregnant lady who has a history of travel to designated hotspot areas or countries, or who has been exposed to a confirmed or suspected case of COVID-19 should be isolated as per the guidelines. When do you say a neonate is exposed to a COVID-19 infection? If the baby is born to a mother who has had history of a COVID-19 infection 14 days prior to delivery or within 28 days after delivery, or the baby has postnatal exposure to COVID-19 infection, it may be a family member or caregiver or even health personnel, they are said to have been exposed to a COVID-19 infection. The management during labor is almost the same. They need continuous fetal monitoring. There needs to be a separate delivery room and operation theater for delivery of such suspect or confirmed cases. And there is no evidence to suspect whether one mode of delivery is superior to the other. You need a separate team for the resuscitation of such a newborn wearing the personal protective equipment. The resuscitation area could be adjacent to the delivery room, or if in the same room, it should be at least 2 meters apart from the mother. All resuscitation guidelines are as per the NRP, and the umbilical cord is clamped immediately and skin-to-skin contact is avoided. And if positive pressure ventilation, you can use a self-inflating bag. But you have to remember that aerosol generating procedure should be avoided. Should the mother and baby be separated? It depends on whether the mother or baby is symptomatic and whether the mother is COVID-19 positive or not. If the baby and mother are stable and the mother's swab result is negative, the baby may be roomed in from the mother. She may be kept in a separate bassinet about 6 feet away from the mother, and a healthy caregiver may be designated the care of the baby. And rooming in can be done in such situations. And you need, if the baby is symptomatic or the mother is symptomatic, you need a separate area for isolation. Or if the mother is a confirmed case of COVID-19 positive, as of now, if facilities are available, the baby should be nursed in a separate area. So all facilities for isolation and monitoring of such babies should be available. And if facilities for isolation are not available, the mother and baby can be in the same room. Now, is there any contraindication for breastfeeding? We all know that so far there has not been any demonstrable presence of the virus in breast milk. And if the benefits, definitely they do outweigh the risk, so breastfeeding may be permitted. But we have to take certain precautions while breastfeeding, because even though it is not transmitted through breast milk, the other forms, the direct contact between the mother and the baby can cause transmission of the virus. So during breastfeeding, the mother should perform all the hand hygiene precautions, and she should wear a face mask, and she should avoid coughing and sneezing. And if not possible to do direct breastfeeding, she can give express breast milk. Care has to be taken while handling this breast milk and transporting it to the baby, and a healthy caretaker may be entrusted with this task of giving the breast milk. If breastfeeding is not possible, formula feeding can be adhered to if the mother is very sick or symptomatic and she is separated from the baby. For a baby who is sick soon after delivery, symptomatic babies you will have to have a designated separate NICU, ideally with a negative pressure, to keep these babies. And if negative pressure rooms are not available, can be created by using 2 to 4 exhaust fans, and central air condition should be avoided in these NICUs. There should be a separate set of personnel to take care of these babies, doctors, nurses, other than those who are working in an ICU, who are trained in basic neonatal care. And these staff should be provided with all the required supplies of personal protective equipment. Respiratory support, all the neonatal care for such babies as per all the existing neonatal guidelines. When you are using procedures like suctioning, or when you are using aerosol generating procedures, special care has to be taken care of. As of now, from the various case reports that are coming from high density areas like in China or Iran, they have not found any specific benefit of using these antiviral drugs or chloroquine or even IVIG, and they're not as of now recommended for use of symptomatic neonates born to such mothers. Is a routine testing of the neonate required? If the mother is negative and the baby is asymptomatic, there is no need to test the baby. But a baby who is born to a confirmed COVID-19 positive mother requires a nasopharyngeal swab to be taken. The first swab is taken at 24 hours, followed by a repeat swab at 48 hours. And if the mother is sick or if she is COVID-19 positive, how long should she be separated from her baby? If she is afebrile for 72 hours and she has respiratory symptoms have improved, and 2 of her swabs taken 24 hours apart are negative, then the mother can take part in the routine care of the baby. And routine screening may not be possible in such babies because they are nursed in separate areas. We are following cord TSH for babies during this period. Pulse oximetry screening is done. Hearing screen, we are sending them home, and we are calling them for follow-up at a later date after 2 to 4 weeks after the period of isolation is over. All the routine neonatal immunizations may be given to these babies. If both the mother and baby are asymptomatic, we can discharge them as early as possible, 24 to 48 hours, after explaining all the risk factors and danger signs, and they may be kept on frequent telephonic follow-up and given a date for follow-up until their period of isolation is over. We also have to take care of, even though luckily for us, these newborns are not much symptomatic till now, they have a high potential for being carriers or asymptomatic. There is a risk for the healthcare professionals who take care of such babies. So especially when pediatricians are going for their postnatal rounds, we should maintain social distancing while communicating with the bystanders and the mother, and we should use facial mask and hand hygiene, and restrict the number of bystanders, because many a times the history may not be forthcoming and the baby may be asymptomatic, so we may not be really suspecting a COVID in such babies. So it is always better to be careful when rounds are being done. So hopefully for us, since so far the baby reports that we are getting from all over the world, the cases are only other than a few rare case scenarios, there are very few neonatal COVID direct vertical transmission, but recently saw in the news about 8-day-old baby acquiring the infection postnatally. That short experience in SATH hospital, we had about 5 cases so far of mothers who are being referred because of suspect COVID. Luckily for us, none of the mothers were turned swab positive, and the babies were okay, except for one baby which required intensive care and oxygen for a few days. And none of the babies were tested because the mothers were swab negative, and except for 2 babies which are still, all the others have been discharged home. So hopefully for us, for neonates, this infection does not cause a threat, but we still have to be careful and look after our own safety. Thank you.
Dr. Radhika, for the interesting talk. Now we have a second talk by Dr. Kristin Indumathy, Senior Consultant Neonatologist, SUTH Pattom. The topic is preterm and low birth weight care. Indu madam?
Yeah, I think I've been muted now. I think the screen has to go away and says you can't start screen. Sorry for the delay. Good evening, and I especially thank Dr. Bennett and Dr. Priya for inviting me over to be a part of this Zoom. And I really enjoyed this small teaching session with you, although it's going to be a very basic topic. I just going to give a brief outline, and then we will be having some basic things to be mentioned about preterm and low birth weight care in the setting of not a very high level setting, but the smaller hospital. Okay, so once again, we are all familiar with many of these terms. But briefly, we need to know that there is a term called late preterm also, which we really don't worry so much, but they are also another burden which we are facing. And therefore, the preterm comes under 35 weeks, and 35 to 37 weeks is a late preterm, which we'll also include in our discussions because they also have a lot of issues coming, and we are facing them more in the smaller setups. And what about, according to gestation age, we can divide them into late preterm, 35 to 37, 34 to 37 weeks, and less than 28 weeks would be extreme preterm. According to the weight, you can classify them as low birth weight less than 2.5, the very low birth weight less than 1.5, and ELBW that is extreme low birth weight less than 1. So why are we looking at all these numbers and these figures? We need to have a conception in our mind when a baby is born. Sometimes we get babies who we don't even know the dates. So we have to know charts, the weight, and the destination in order to classify them either it's a preterm or it's a term SGA babies. So these things have to be very clear in our minds. And we know that the neonatal deaths, we take maximum number occurs in the first week. And even in our death audits, we've been clearly seeing that the preterms are dying earlier because of their lack of, because of the maturity itself. Now, all these babies who are less than 2.5 kg or 2,500 grams, they are called as low birth weight babies. They include both preterm and term small for days. And in India, we have 68 million low birth weight infants. It's not a small number. And all of us will be looking at these babies. Almost every hospital will be looking at these babies, many even the days to come. So I'm not going to deal with a very extreme low birth weight, or we're not going to talk about very high stuff here, but basic stuff. So I think many of you are familiar with this chart where we assess the maturity of babies, how many weeks. So this is called the new Ballard score, and I think many of you know. And even if you don't have a thing, you can always get it in the net. Keep one with you when you're practicing to assess the maturity. And this maturity assessment usually is within 24 hours. But in case a child is sick, you can even go up to 48 to 72 hours. You can still have a maturity check on the baby and know how many weeks. So what are the causes of these preterm babies? We first talk about preterm births. Mainly, there are maternal factors and the fetal factors, and then you have the iatrogenic factors. Maternal factors, the list is here. You have the medical disease in the mother, mainly the PIH, the pregnancy-induced hypertension, then your renal disease, RH, diabetes mellitus, then your complications of pregnancy like placenta previa, hemorrhage, then maternal infections, a UTI, and a previous history of prematurity and incontinence of cervix. These are some of the reasons among the list to know about the maternal factors. Then you have the fetal factors. Of course, multiple pregnancy, we all know that more than one pregnancy always may end up in a preterm birth, and there are congenital malformations. Sometimes we get mistaken dates and we find that these come out preterm. So we don't know whether they are 34, they are 32 or 35. So that is also cause mention. Now we have to understand about the preterms when you're dealing with them. They have specific physiological handicaps. First of all, we know that the central nervous system is immature and they are poor in feeding, lethargy, cough reflex, sucking, swallowing is not there. So these babies are different and there is difficulties, resuscitation, and one has to be prepared for that too. Recurrent apnea is also common in preterm babies. ROP and retrolental fibroplasia due to oxygen toxicity is seen more in less than 35 weeks babies and extremely vulnerable to develop periventricular hemorrhage and periventricular leukomalacia. Interventricular and periventricular hemorrhage and leukomalacia. And then the blood-brain barrier is actually not very efficient in these babies. Therefore, even smaller levels of bilirubin may be hazardous to these babies, which we should really take into account when we start phototherapy for these babies. Now, some pictures to show you what is intracranial hemorrhage, periventricular leukomalacia, and intraventricular hemorrhage. Now, what about the respiratory system? We know that these babies can be born with deficiency of pulmonary surfactant and lung immaturity, and atelectasis and pulmonary aspiration is common, and they are also prone to develop bronchopulmonary dysplasia. And the problem is due to lack of surfactant. The cardiovascular system, we may have the PDA, which is delayed closure in these babies, and some of them go on to have even congestive heart failure. They can have some hypotension secondary to cardiac dysfunction or even sepsis. And we all know the gastrointestinal system, they're very too early out. They come early. So how do we feed these babies? They have very small capacity of stomach. Regurgitation is very common. Aspirations can occur. There is a reflux going on, and they get abdomen distension and functional obstructions due to hypotonia. NEC is necrotizing enterocolitis is seen in children who are preterm and also in below birth weight babies. And we can get a lot of derangements in the metabolic place where we have hypoglycemia, we can get hypocalcemia, magnesium, etc. Now, talking about thermoregulation in these babies, we know that they are extremely vulnerable and it is life-threatening to these babies. And there is insensible water loss, and the surface area is very huge. So, and there is paucity of brown fat. These babies are not able to maintain the temperature. So we have various methods now. We have the radiant warmer, the incubator, and we've seen these babies. You can see them all wrapped in plastic covers. And now we have so many methods of keeping them warm in the delivery place, making them safe. And even 1 degree drop of temperature has an increase in mortality in this baby. So we have to prevent hypothermia in these babies. So how do you prevent intracranial hemorrhage? We can prevent antenatal steroids is very important, and avoid these blood pressure fluctuations in these babies. So these babies have to be handled very, very carefully, very carefully when you're doing a resuscitation, during a transport. All these things matter, and when you're taking care of babies, you have to train your unit staff and your doctors to handle these babies so that even prevent even intracranial hemorrhage can be prevented in a large way, intraventricular hemorrhage. And a small few pictures about necrotizing enterocolitis, which is seen in these babies commonly. And we have a reduction because now we are using more of breast milk, and we find this less in number, and sepsis is less, it is coming down. So another problem with these babies is their oxygen, and some other factors, inflammatory factors, produce retinopathy of prematurity. And one has to take care to check our babies very early. In fact, as early as even 2 weeks, we need to check the retina so that their eyes have to be clear and they don't form, they don't need to have further treatment. So now this is the treatment we go for retinopathy. So going with this, some of the problems which we face in the preterm babies, we have one important message here: the antenatal steroids, which have to be given in preterm age. It saves a lot of lives. 50% reduction in incidence of respiratory distress syndrome, 50% reduction in intraventricular hemorrhage, and 40% reduction in mortality. Isn't that a big thing? So I think make sure that all the preterm mothers are given the steroid before they're taken up for delivery. And some more problems are infections, renal immaturity in these babies. Then they're prone to develop anemia, vitamin E deficiencies. I already mentioned biochemical disturbances, and they're more toxic to drugs, common drugs which we administer. So be careful. So let us go to the principles of management of preterm infants. The broad line I'm going to give, you can ask questions later on. First of all, the delivery and resuscitation stabilization should be in a suitable place. You understand what a suitable is? that this hospital should be equipped for preterm delivery. All the equipment and the oxygen levels, we have the blenders now, we have the incubators all ready, and prevention of hypothermia. The staff and the doctors should be trained in preterm delivery. Then the appropriate place of care would be for the smaller babies, they have to be shifted to tertiary level newborn care, whereas some of these babies can be managed in secondary level newborn care. More than 1.8 kilos can be managed, maybe not with the room in the mother initially in the small ICUs and then later on. So of course, thermal protection, you know much about kangaroo care, which is being followed. We start kangaroo care very, very early for these babies, even if they are on the CPAP, on the ventilator. It gives a lot of confidence for the mother, and she also gives more of breast milk, and the baby's growth is also good. Now, going into another real important aspect of fluids and feeds and nutrition for these babies. So I think this is very important when we plan for these babies. The bigger babies, the more than 1,800 grams and more than 35 weeks, those babies can be directly put to the breast. But the smaller ones, between 32 and 35 weeks, will depend on the weight and the baby's house sick. So these babies can be initially started on your nasogastric tube feeding. And what do you give them? Always give breast milk and colostrum initially. However small quantities, please encourage the mother to give that. And then maybe if we have now the breast milk banks here and they're providing us the initial few days, if you can tide over the crisis and you can counsel the mothers, definitely the output of breast milk increases. And you can always do with breast milk. And all of us know the benefits of breast milk. I don't think we need to highlight here. But definitely these babies do very well in terms of infection, in terms of NEC, the outcome, the mortality. They have do very well. So these babies of 32 weeks and about 35 weeks, we need to give them gavage feedings, or we go up to Palada feedings. Then direct breastfeeding. So what about the smaller babies, less than 1.5 years? These are the babies which we need to think about also. So what will be the aim of feeding? For feeding should be approximate to the intrauterine growth in the baby. And the quality of weight gain should be more of protein rather than fat and water. So we need maybe up to 130 to 155 kilocalories, and around maybe even goes up to 180 to 200 ml per kg per day. We know that breast milk contains 65 to 70 kilocalories per 100 ml. So how do you go about? We have a chart. Usually we have in our books, we have charts showing us how to start with day 1, day 2. For smaller babies, we start with IV fluids, but we start with minimal enteral nutrition. What is minimal enteral nutrition? You just give whatever milk the mother gives you, even if it's small, few drops of cholesterol. Just please put it in the NG tube and give it to the baby, because this will prevent your intestinal villus atrophy, and the baby's infection also is prevented. So you start with it and you slowly, gradually increase the feeds. And what is IV fluids in the smaller babies need? It includes your protein, it includes your lipid and other electrolytes also. So these things, I'm not going into details, but I'm sure you know. And how do you advance the feeds? Once you start feeds, it's tolerated. You can advance by 20 ml per kg for the smaller ones and by 30 ml per kg per day for the bigger ones. And you reach up to 180 to 200 ml. So the protein comes in aminovin, and lipid also comes in bottles. So we can calculate, you can start off with 3.2 to 3.3 gram per kg per day of protein, and lipid also equal amounts. Then you can prepare your own TPN, or you can do by the Y method, you can add on to your binge pumps. But it's very essential that all these smaller babies get the TPN initially and then go on to your breast milk. So what are the options we have? We have breast milk, we have formula bank milk, human milk banks coming up. Then we have human milk fortifier, which can be added on to the breast milk so that you get the proper calories. Now, the calories I already told you, we need protein also. How much protein do we need? Around 3 to 4 grams per kg per day. Now, we all know the unique substances in human milk. I don't think we need to go into details, but I've already spoken about these things. Now, these charts also one should get familiar in your ICUs. We need to monitor the weight, etc. length. So, if by 10 days, if your birth weight is already reached, I think you're quite good. But Maintain, have a goal, set your goals so that at least 15 grams per kg per day weight gain should come. And all these 3 parameters are important for preterm growth. It's not weight alone. Then, of course, you have to give the babies vitamins, and vitamin K is initially given at birth. And most of our vitamins which we get now, the Abdec or the Vicemerals and all these things have the vitamins, and we have also know how much to give. Now, iron can be started by at least 4 weeks, but usually we try to start it a bit earlier, especially because we draw a lot of blood birth from these babies. And calcium and phosphorus is given either by human milk fortifiers added to the breast milk, or you can give it by the syrups which are available. And of course, the other complications, we have to be very careful in the early use of phototherapy. We have charts which tell us the NICE charts available from UK. Then we have the Bhutanese charts which tell us when to start phototherapy. And remember that these babies may need longer times of phototherapy. Infections, we have to have a very careful evaluation, a very low threshold for starting antibiotics. Same time, you have to stop antibiotics once your cultures are negative. Do not give prolonged antibiotics. PDA can be usually conservatively managed, and supportive care may be necessary, even sometimes PDA. And we may have to give paracetamol or brufen. Now, what about vaccinations? All vaccines can be given according to chronological age, except for hepatitis B, which they say maybe if you can give it after 2 kilos, immunize it, the immunity is better. Some children do develop post-vaccination apnea, preferably the small ones. Try to give vaccination once they shifted to the ward and make them stay for a day on monitor them. And we do not have to have these unnecessary fears about vaccination partners. Do not adjust any age for preterm birth, saying that the baby is small, too small. Don't adjust. Now, what is cocoon strategy, which actually now they're following the Western countries? Tdap is given instead of TT, so that the mothers are mothers, and the older generation of grandmothers and grandparents are there who take care of. They're all given Tdap, so that the child does not get informed. This is just a guideline of a preterm whose mother is hepatitis B positive. If she's hepatitis B positive, then you have to give the initial vaccine and then give the other 3 doses also. And at 9 months, we'll have to test the vaccine's efficacy. If it is negative, you can delay up to 2 years. So what are these IUGR babies and how are they different from preterm? We know these IUGR babies are actually almost term babies, and they can be classified as asymmetric, symmetric, mixed. Now, the asymmetric ones are more of chromosome and genetic anomalies. Asymmetric ones are the malnourished ones who do not get the proper growth from the mother. Now, how are they different? They're by weight-wise and feeding, all that we may have to go similarly like the preterm, but definitely there, and they have a lot of environmental constraints when they were inside the womb, and therefore their physical growth may be retarded, and even they may not catch up for a longer period of time. Some children tend to do badly in terms of learning dysfunctions. So these babies are really important, and they have to be terminated at the right time before the end diastolic flow. So these babies also, feeding and other things may be similar to those babies, but you must keep careful of these babies before you discharge them. Now, what should we avoid in preterm babies? Don't give simply oxygen without monitoring. Don't give immunoglobulins for prophylaxis. And prophylactic antibiotics is not there anymore. Even for preterm, we stop antibiotics as early as possible. And unnecessary blood transfusions. Keep your ICU without excessive light and sound and rough handling. And have a follow-up protocol for these babies, the preterm and the low birth weight babies, because they will come back to you with all sorts of problems. They may not have gained weight, they're anemic, neurodevelopment, all these things may be impaired. So they must be checked for eyes, hearing, behavioral problems, language disorders, learning disorders. So they are going to come back to you constantly and have a protocol, follow them up very closely, and you will see them come back to you again better. So I think I'll stop with this, and thank you for listening.
Thank you, Madam, for the extensive talk. Now I invite Dr. Kamala Swarnam, Senior Consultant Neonatologist, Ananthapuri Hospital, Trivandrum, to talk to us on feeding newborns and its issues. Dr. Kamala.
Good evening, everyone. At the onset, let me thank Priya, Praveen, Bennett sir for giving me this opportunity opportunity to Zoom. And my topic is very common topic, feeding of newborn and its issues. I'm pretty sure that everybody knows everything about feeding of newborn, and this might be only a revision. So coming to my topic, even when you talk about the principles of care at birth, establishment of breastfeeding comes during the initial 5 principles. And we know that as soon as baby is delivered, for the routine care, baby is delivered on the mother's abdomen. And after the routine care, dry, remove wet linen, cover, label, everything, we around 1 to 3 minutes, there is delayed cord clamping. Then the baby is put skin to skin care in between the mother's breast. There is breast crawl, rooting, sucking, and then there we go, initiate breastfeeding. And we know that early contact between mother and newborn enables breastfeeding along with the other best practices. And the advantages of breastfeeding, as everybody knows, it's a complete food, species specific, easily digested and well absorbed, decreases development of allergy, eczema, asthma, etc. Protects against infection because it is full of live cells, antibodies, protective factors, promotes emotional bonding, better brain growth because of the presence of neurovitamins and other factors like docosahexaenoic acid, etc. Contains essential amino acids, PUFA, contains better bioavailable iron and calcium, and less heart disease, diabetes, and lymphoma, the beneficiaries. And benefits of the mother includes helps in involution of uterus, delays subsequent pregnancies, helps in family planning, and lower risk of breast and ovarian cancer, and decreases mother's workload, and helps in saving money. It's a clean, portable, and cheaper option for feeding, promotes family planning, decreases need for hospitalization, and contributes to child survival. So when we talk about breast milk, we know the contents of the breast milk, and we know that it contains all the, except from the proteins, fats, and sugars, it contains live cells and also all the protect immune factors like immunoglobulins, cytokines, chemokines, antibodies, especially IgA antibodies, hormones and growth factors, lactoferrin, oligosaccharides, whey protein, etc. And last not the least is microbiota. And the breast milk microbiota, we have at least more than 1 million counts of bacteria in our breast milk. It is rich in microbiota and is viable skin and non-skin bacteria. This cannot be cultured, usually identified by microbial DNA signatures, and there is definite evidence to say that they enhance the immunity, liberate nutrients, and they synergistically act with the breast milk oligosaccharides to enhance the intestinal barrier function and strengthen the functional gut-brain axis. Even though they have a complex process and which is not clearly elucidated, there is definite evidence to show that there is certain definite impact on the infant growth and development. And when we talk about the good guys, who are the bad guys? So whenever we go from breast milk to infant formulas, so there, the firmicutes, these are the genus of bacteria, gram-positive bacteria, and they overgrow, and the ratio to bacteroids ratio of firmicutes to bacteroids increases. This correlates with obesity and type 2 diabetes. There you go with the theory regarding formula-fed infants having lifestyle disorders. And we know that there is definite benefit for breast milk in preventing newborn deaths, underfed deaths, preventing diarrheal and pneumonia mortality, benefits in raising IQ, non-communicable diseases that we talked about, lesser hospital stay, and the maternal benefits. And the main reflexes that helps in breastfeeding are the prolactin of milk secretion reflex and oxytocin of milk ejection reflex. So the milk secretion reflex, after the first feed, this helps in producing the next feed. So enhancing whatever factor which helps in emptying the breast, helps in increasing the production of prolactin, that is suck, expression, emptying, and especially we have to talk about night feed. So there is increased secretion of prolactin during the night. So frequent night feeding also helps in increasing the prolactin secretion. And anything that decreases the breast emptying, like incorrect position, painful breast, pre-lactal feed, stop feeds, etc., decreases the prolactin secretion and decreases the milk secretion. And oxytocin milk ejection reflex, and oxytocin it contracts the myoepithelial cells and helps in milk ejection. And these are mainly emotional factors. As soon as the baby is put to the breast, thinking lovingly of the baby, sound and sight of the baby, and a confident, relaxed, comfortable mother. All these things are the enhancing factors for oxytocin reflex. And any negative emotion like worry, stress, pain, and doubt, this decreases the oxytocin. So here comes the importance of a kind, patient, and supportive person. It may either be a professional health worker or a relative to reassure the mother and help her gain confidence so that she can successfully breastfeed. And every facility who has deliveries should have such a person who is trained in lactation counseling. It can either be a doctor, it can be a nurse, or a therapist or a development therapist who is trained in giving lactation, patiently giving lactation counseling. So these feeding reflexes helps with the breastfeeding, including sucking and swallowing reflexes. And coming to the types of breast milk, the initial milk that is secreted during the first 3 to 5 days is called colostrum. It is thick and yellow, and the yellow color are attributed by beta carotene. It is more a live milk containing antibodies and leukocytes, which is called as a first vaccination for the. From around 3 to 5 days to up to 2 weeks, it's a transitional milk. Content decreases and the fat and sugar content increases. Till after 2 weeks, the mature milk comes, which is thinner and watery, contains more sugar and more fats, and which is more calorie dense. The colostrum, it is about 65 calories per deciliter per 100 ml, and mature milk is around 70 calories per 100 ml. And it contains all the nutrients essential for the optimal growth of the baby. And we know about the foremilk and the hindmilk. Only if the baby completely empties the breast, that is both the foremilk and the hindmilk should be sucked in order for the complete nutrition. The foremilk is mainly rich in protein, sugar, water-soluble vitamins, minerals, and water. This satisfies the baby's thirst. But the hindmilk has a more richer fat content. This is important for satiety and also more calorie dense, and it is essential for the better growth of the baby. So feeding a baby who's not hungry will result in baby not sucking vigorously, sucking only for a small time, and this can result in something called foremilk syndrome, which everybody is familiar with. So there will be excessive crying, a gassy baby, passing flatus, and more vomiting, etc. So always stress the importance of completely emptying one breast. So most often one breast is enough for one feed. So advise a mother to completely empty the breast, feed for around 20 to 30 minutes at least, and proper burping before going to the other breast, or for the next feed you can go to the other breast. And for a successful breastfeeding, a willing and motivated mother, active sucking and input, and a motivator is needed. And we should have a written breastfeeding policy, and even during antenatal period we should be counseling her regarding the importance of breastfeeding. Early breastfeeding right on the labor and delivery room immediately after feeding. That is, in the first few minutes of the feeding itself, you can initiate breastfeeding. Skin to skin contact, rooming in, frequent feeding, no pre-lactal feeds, no bottles. Support the mother, early tackling of breastfeeding problems, exclusive breastfeeding for 6 months, and complementary feeds for after 6 months. And teach her regarding the various positions, breastfeeding positions, and it is better for you to have a book or a colorful picture book showing her the various positions, proper latch, so that it is more easily understandable to everybody. And latching, you should teach how to make the baby latch. The chin touching the breast, lower lip curled outwards, wide open mouth, more areola visible above than below. And everybody should be knowing, everybody who is taking care of a newborn should be knowing about the latch score. The nurses should keep this copy in the nursery, and during every shift, at least 3 times a day, the nurses should assess whether baby is having proper latch. So they should score the baby. If baby is having a score of 7 or less, there should be retraining of the mother, and we have to be very patient with the baby and the mother and teach them how to do proper feeding and latching. And poor attachment, we know that it leads to pain or damage to the nipple or sore nipple, breast engorgement since the milk is not removed effectively, hungry and irritable baby because of poor milk supply, poor weight gain, jaundice, hypoglycemia, dehydration, pre-renal failure, hypernatremia, and occasional hematemesis due to cracked nipple. And mother should know that a healthy newborn should be breastfed on demand. That is, whenever the baby cries, baby should be fed. Usual time interval, if the baby is fed properly, is usually 2 to 3 hours. And at least mother should be feeding the baby at least 8 to 10 times a day. And importantly, make her aware of the importance of night feeds. As we talked earlier, during the night time, more prolactin is secreted. So night feeds are important. Frequent night feeding is important for more secretion of milk. And breastfeeding is considered adequate if the baby sleeps well in between feeds, passes urine 6 to 8 times a day, crosses birth weight by 2 weeks, gains at least 25 to 30 grams per day after the initial 10 days. The most common problem that we encounter is not enough milk. What are the causes of not enough milk? So most common, they might even call you after they get discharged, telling that baby is crying incessantly, there is not enough milk. So we should be asking certain questions. So what are the causes of not enough milk? Not breastfeeding often enough, too short or hurried breastfeeding, night feed stopped early, allowing the baby to sleep longer during the night, poor positioning and latching, poor oxytocin reflex because of lack of confidence and anxiety in the mother, engorgement or mastitis. So we have to ask the correct questions to find out what is the reason for the not enough milk scenario. And we have to identify the cause and counsel accordingly. And the management is tell her to put the baby to breast more frequently, correct the position and attachment if it is wrong, and build the mother's confidence and use galactose judiciously. If the mother is at home, call her to your nursery or wherever you want to examine the baby, sit with her, go through all these questions, examine the baby, look for the weight gain, ask her how many urines per day there are, and reassure her that you are doing well, that weight gain is good. That just crying alone is not an essential, it cannot be called as not enough milk. So reassure her, give her confidence, and tell her that it will be enough if there is adequate weight gain and urine frequencies around 6 to 8 times a day. So common problems that we encounter are inverted nipple. We know that how to test for the inverted nipple, then manual stretching and rolling, and then the syringe technique, the inverted syringe technique and the double syringe technique. Sore nipple, most common cause of sore nipple is nipple sucking. Baby is not properly latching on the breast, and the frequent use of soap and water, and it can be thrush also, fungal infection also. So how to treat it? Continue breastfeeding with proper attachment. Hind milk can be applied to the milk after a breastfeed in order to prevent the soreness. Expose the nipple to air in between feeds. Avoid tight clothes, and take a look at the breast to see whether it is any thrush or fungal infection. Breast engorgement. So whenever there is a delayed or infrequent breastfeeding and incorrect latching, breast can be engorged. And the causes for a painful tender breast, either a vascular enlargement or it can be a plugged duct can also produce a painful and tender breast, and also mastitis. In mastitis, usually mother has systemic illness like fever, malaise, and a hard, tender, red breast. So if the initial two causes, that is vascular enlargement, we can manage with cold compresses, massage it, and see what the problem is and advise her correctly. If it is a plugged nipple, massaging will help, and even warm pads will help. And changing the position of the sucking of the baby can alter the, around 180, 360 degrees, you can rotate, you can position the baby in such a way that the block is relieved. So that is another method we can give relief for the breast engorgement. If it is mastitis, initially conservative management like analgesics, lots of fluids, the rest. Sure. And massaging and expressing milk prior to feed. And if it is not working, go for antibiotics which is sensitive. And so these are the causes for the painful breast enlargement. And also talk to her about breast milk storage. If the mother cannot exclusively breastfeed till 6 months of life, talk to her about the breast milk storage, how to do it. So, usually the reasons are maternal or baby's medical conditions, and if the mother has to go to work or for studies early. So, give her clear ideas about personal hygiene, how to use the equipments, what the containers that can handle this, wide mouth, clean container, glass container preferable, or there are other breast milk storage bags which are available. To avoid plastic contains BPA. So give the clear instructions regarding how to do that, and they should know how long they can keep the milk outside or in the refrigerator. The freshly expressed or pumped milk can be kept at around 25 degrees Celsius or colder up to 4 hours. Inside the refrigerator around 4 degrees Celsius up to 4 days. If in deep freezer at minus 18 degrees Celsius, it should be used within 6 months. Once the milk is taken out from the freezer and thawed, it should be used within 1 to 2 hours if it is kept outside. And if you're going to refrigerate it, up to 1 day, but never put the thawed milk back on in the freezer. So in order to maintain the lactation, especially for preterm babies, and in order to maintain the lactation when you're pumping, tell her to express milk every 2 to 3 hours during during daytime, at least once during the night, with a total of 6 to 8 times per day. And more prolactin is produced at night, so breastfeeding expression at night is especially helpful for keeping up the milk supply. And my last slide. Supplementation. So we don't need a multivitamin supplement, B-complex vitamin supplementation for healthy, term, good birth weight babies. But vitamin D is mandated, 400 international units daily up to 1 year, from birth up to 1 year. And iron supplements, now iron supplements are recommended from around 4 to 6 months of life. The iron stores in the breast milk will last till around 6 months. But if the mother is deficient with the iron stores during the 3rd trimester, they might need iron early. So around 4 to 6 months, we should start iron supplementation around 2 to 3 mg per kg per day, up to maximum 15 mg per day.
Thank you, Dr. Kamala. Now we have our next talk, Common Issues in Newborn Office Practice. We have Dr. Hazeena, Senior Consultant Neonatologist, NIMS Hospital, Trivandrum, with us to talk on that topic. Dr. Hazeena.
Yes, good evening, friends. And at the outset, let me thank Bennett sir and Priya, Anju and Praveen for all at IAP for giving me the opportunity for this. So today's topic is common neonatal issues in office practice. So in the daily OPD practice, we usually get to see different categories of people. Like we call the babies for review for checking weight, assessing lactation, checking the bilirubin, and another group of parents come to clear their doubts regarding the skin lesion, the bladder and bowel habits, vomiting, feeding, umbilical bleeding, withdrawal bleeding, breast swelling. Then there are maternal issues like cracked nipple, engorged breast, retracted nipple, as Dr. Kamala was highlighting now. And some parents have little more worrying issues like excessive cry, umbilical sepsis, eye discharge, skin problems, then abnormal movements, even breath holding spell. And there are other babies with more severe issues like respiratory distress, hypotonia, seizures, infection, poor activity and feeding, abdominal distension, recurrent vomiting, diarrhea, and blood in stools. So when we are in practice, when we do the basic principle that all of us should have in mind is identifying the problem in a newborn is the complete responsibility of the doctor who is seeing the baby, because these are newborn babies, these are small babies who cannot communicate. Even parents may not be able to tell completely regarding the complaints of the babies. So while evaluating, we need to have proper antenatal, perinatal, postnatal history, which is very relevant. The blood group of the baby, the gestational age, the birth weight has to be noted. And it's better to have a look at the discharge summary of the baby and keep the note of the history regarding any follow-ups that is already mentioned or advised to the parents, like renal scans or echo or eye evaluations, etc. And while examining, we should have a look at the overall activity of the baby and the sleeping pattern. Head-to-toe examination is mandatory, and vitals examination, including the STOPS evaluation, that is the sensorium, the temperature, the oxygenation, and the respiratory pattern of the baby, the perfusion and sugar values need to be evaluated. System examination, skin examination, and examination of the genitals are mandatory. The whole common illness in this 10 minutes time, but let me go into some of the commonest ailments with which the parents come to us. One of the most commonest thing which we all might have seen is colic, and parents usually come frantically to us with excessive cry, especially during the evening hours and night. Some high criers are there who cry for as long as 4 to 5 hours. Some of the babies settle by around 30 minutes. Colic usually starts by 2 weeks of age and settles by 3 to 4 months of age. It's actually not a disease. This is what we need to convey to the parents, that it's actually not a disease, but a behavioral disposition of the baby. So on our part, what we need to counsel the parents is that we have to be in more happy while handling the baby, talk to the baby, sing to the baby, and handle the baby in a better way, which gives more comfortable to the baby, rock the baby, and take the baby for a drive even. This will actually help to Hello?
Yes. We can hear, you can talk. Yeah.
Yeah, this will actually help to this will actually
Slide
help.
share ചെയ്യുന്നുണ്ടോ?
Dr. Hazeena, slide
share
share
ആയിട്ടില്ല.
ചെയ്യാനുണ്ടോ? ഇല്ല, share ആയിട്ടില്ല. Share screen.
Share ആയിട്ടില്ല. Oh, sorry. അതാണ്. ഒരു സെക്കൻഡ്. എനിക്ക് ആക്ച്വലി ആ സൂം ഓക്കെ സോറി. ആയോ? ഇപ്പം ആയോ?
ഇല്ല.
ഞാനിത് കൊടുത്തിട്ടുണ്ട്.
ഗ്രീൻ ബട്ടൺ ഷെയർ സ്ക്രീൻ.
അതെ, ചെയ്തല്ലോ.
അതിൽ എന്നിട്ട് ആ പവർ പോയിന്റ് ചൂസ് ചെയ്താൽ മതി.
ഓക്കെ. വന്നോ?
ഇല്ല.
സോറി. ഒരു സെക്കൻഡ്, ഞാൻ ഒന്ന്
ഓക്കെ.
Hazeena, continue ചെയ്തോളൂ.
കേൾക്കാവോ?
കേൾക്കാം. ഫുൾ സ്ക്രീൻ ആകാതെ.
ഓക്കെ, സോറി. ബിഗിനിങ് വേണ്ടല്ലോ, ഞാൻ തുടക്കം തൊട്ട് വേണോ? ഹലോ,
ജസ്റ്റ് സ്ലൈഡ്സ് ഒന്ന് കണ്ടാൽ മതി, ജസ്റ്റ് ഒന്ന്. ഓക്കെ.
സ്റ്റാർട്ട് ചെയ്യട്ടെ?
ഓക്കെ, സ്റ്റാർട്ട് ചെയ്തോ.
Okay, so we were talking about colic. കേൾക്കാലോ?
കേൾക്കാം, പറഞ്ഞോളൂ.
Okay. So most of the parents come to us with the complaint of excessive cry, and the babies cry for as long as 4 to 5 hours, and there are babies who settle by 30 minutes, and it starts by 2 weeks and settles by the age of 3 to 4 months. So I've already told that a happy disposition from the side of the parent will help in relieving the baby's colic, because it's actually a behavioral disposition rather than a disease. So medication is of least importance in this scenario. But we have to be careful that while we rule out the ear, like we need to rule out such infections in the baby, like ear infection. Even insect bite can cause excessive cry for the baby. And if feed is sufficient, and if we have wrapped the baby properly, and if we have given proper burping to the baby, then it shouldn't be of much worry. Like if excessive cry is there, then we need to take care of the baby in such a way that we handle the baby properly and take the baby for a ride or talk to the baby and give a rocking moment. Most of the time it will settle. And many parents return back to us saying that by 3 months of age, the behavioral disposition has been rectified. Now, there is another cause as well, the perianal excoriation, which is really painful for the baby. So we need to examine that part as well. And some rare conditions like hepatoblastoma, when the liver capsule enlarges, and that can be really painful, and intestinal obstruction. These rare things also has to be kept in mind. Now, another common condition with which the parents approach you is vomiting. There will be usually curdy feed. Sometimes it will be milky as well. Usually it will be 1 to 3 episodes per day. Some babies might have 5 to 10 episodes per day as well, and proper burping will be a solution for this. Overfeeding should be avoided. We need to advise the parents regarding the position after feeding, that is a slightly head and elevated and lateral position. And advise the parents regarding the lateral position even while the baby is vomiting in order to avoid aspiration. If we check the weight gain of the baby and we note that there is a proper weight gain, then we can be confident enough that this vomiting is not of much medical issue. So medication also is not mostly indicated. Now, other causes of severe vomiting like hypertrophic pyloric stenosis, where there will be projectile vomiting and inadequate weight gain, has to be kept in mind. Then gastroesophageal reflux disease also has to be kept in mind. And bilious vomiting is a danger sign for the baby. Always listen to the parents. Green vomit is surgical. Vomiting plus distension is surgical. Vomiting plus shock is also surgical. Now, coming to the skin conditions, most of the skin lesions like the erythema toxicum, the transient pustula, melanosis, milia and miliaria, neonatal acne, and seborrhea, all these are normal phenomenon for the baby, which just requires reassurance to the parents. No medication is indicated, except the advice that we should not use any irritant on the baby's skin, irritating objects, or applies too much of ointments and creams. And some parents even use materials which are like clothes. There is diaper rash and the candidal infection and perianal skin rash, which can be really frightening conditions. Like in diaper rash, we have to advise them to remove the diaper as frequently as possible and make the area dry, air dry the area, and applying zinc oxide will help in these areas. To differentiate from diaper rash, to differentiate the candidal infection from diaper rash, we need to see the flexural areas. The diaper rash, where the diaper is not coming in contact with the flexures, will not be affected. The flexural areas will not be affected in diaper area. Now, there are infective conditions like staphylococcal pustula lesions, impetigo, abscess in various areas, especially the mastitis neonator as well. Then regarding the seborrheic dermatitis, it is actually a condition where there is dry skin all over the body, including the scalp where there are scales. And here again, we can advise them to apply moisturizing ointment, avoid moisturizing cream, avoid irritating materials, especially applying too much oil can be damaging to the baby. Now coming to the umbilical problems, clean tie, clean cut and clean handling is what is recommended. No local application of any ointment is recommended. We can bath the baby but keep the area dry. Only if there is foul smell, discharge or redness, it is suggestive of infection. Erythema and induration of the area suggest systemic infection, so systemic antibiotic is recommended. Now, there is another entity called umbilical granuloma, which is actually not an infection, but a tissue overgrowth. So this can be cauterized with copper sulfate crystals. Now, another important complaint for which the babies are usually brought are cough and upper respiratory infection. Mainly parents complained about nasal block and nasal discharge while feeding and sleeping. Actually, the nasal block and sneezing is a normal phenomenon which doesn't require any medication. Sometimes it can progress to cough and feeding difficulty. We need to look for chest signs, retractions, the grunt, alar flaring, and all those respiratory patterns have to be evaluated. Sometimes it could be viral infections progressing onto bronchiolitis. Such babies require admission. Now, there is another episode of another event that usually is brought as apparent life-threatening episodes, which occurs usually after bathing or during bathing, after feeding, while sleeping, or during vomiting. And usually the parents or the bystanders bring the baby in a very rushing and tensed manner, and they have to be kept in lateral position, and airway breathing circulation has to be assessed as well as the vital signs. If there is any blockage because of the water or feed, we have to provide suction to the mouth as well as the nose, and the baby need to be observed for at least an hour, including we have to observe whether the baby is able to feed well and the baby is active or not. Now, in conclusion, I'd like to tell that there are a lot of common ailments with which the babies are brought to us, but most of them are healthy babies, and most of the complaints that the parents tell are normal phenomenon. So we need to listen to the parents. We need to take our time to clear their doubts. We need to reassure the parents, and we need to tell them regarding some developmental milestones, which is within 3 months of time, what are the developmental milestones, and also regarding the vaccinations. So, and also regarding the danger signs which Dr. Anand will be telling you. So with that, thank you.
Thank you, Dr. Hazeena, for the practical tips too. Now we move on to the last talk of the series, Danger Signs in Newborn by Dr. Anand, Senior Consultant Neonatologist, NIMS Hospital.
Hello. Good evening, everyone. First of all, at the outset, I thank IAP Thiruvananthapuram team for hosting this Zoom session. So my topic is danger signs in newborn. So as you know that why the danger signs? Because we have to reduce the mortality. The WHO position statement tells that 2.6 million babies dies in the first days of life, and most common being the causes being prematurity, complications during birth, and severe infection. And this can be prevented. 3/4 can be prevented. How we can prevent this? We can prevent this only by assessing the newborn. And what are the methods of assessing the newborn? Can go from a complete physical examination, or there are bodies such as WHO says some position statements are there, guidelines are there, scores are also there, such as CRIP score, neonatal acute physiology score, account score, STOP score. There are so many scores are there, but the simple and the easy to do scoring is the STOPs. So in a peripheral working doctor or a facilities are not available, just by looking at the STOPs, you can assess the condition of the newborn. So it stands for, so before going to that, one more thing, STOPs. This STOPs means S for sensorium, T for temperature, O for oxygenation, P for perfusion, and S for sugar. So this comes that STOPs. So who is a well newborn? A well newborn being a baby who is having no risk factors for infection, which is now baby is having normal sensorium, normal temperature, normal oxygenation, normal perfusion, and normal sugar. So what do you mean by sensorium? So first and foremost danger sign that I am going to tell is the sensorium part. Baby is active. Active means that the 99% of neurological examination in a baby is done by just observing the baby. Touching the baby will add some more percentage only. So 99% is by observation. That too, looking at the response to stimulus, baby is having good cry, good spontaneous movements, eye opening, feeding well. This is an active baby, so nothing to worry. But the other way around, the baby is floppy, poor response, poor cry, decreased movements, not sucking well. This is one of the first and foremost danger sign. So now comes the temperature. Temperature you can either assess by the clinically by using dorsum of your hand by touching the abdomen and peripheries, or by using an axillary temperature by using a digital thermometer. Do not add 1 degree. And the thing is, the normal range is, as you all know, 36.5 to 37.5. Any baby having less than 36.5 is called as cold stress. Below that, 36 is being moderate hypothermia. So this is the next danger sign that I am going to tell you. So first was sensorium, next is the temperature. So now coming to the next part is the oxygenation part. That I will go with the each and every system wise. So respiratory system, we will be looking at the respiratory rate more than 60. The rate should be counted in a quiet state and not immediately after feed. And if there is an expiratory grunt or there is subcostal retractions, 2 out of 3 is there, then we will call it as respiratory distress syndrome. And this is the third danger sign in the newborn. So danger signs, how we can assess is by scoring the distress data. This by objectively we can assess the danger signs by scoring the respiratory rate. That's by looking at the Downey score and the Silverman score. So Silverman score is used for mainly for preterm babies and Downey score for term babies, even though both can be overlapped, use can be done. So scoring by for SAS score 0 to 3 is mild respiratory distress, and so 4 to 6 is moderate, and more than 6 is severe. So you can see that the Silverman-Anderson scoring, there is upper chest, lower chest, sigmoid, nasal dilatation, expiratory grunting. Make sure that upper chest means the line that is drawn above the, that is above the mid-axillary line. Part that is below the mid-axillary line is the lower chest. Others you can visually identify. So this is one of the baby having all the time. So automatically it comes this way. Here you can see that the upper chest which is moving upwards, and there is a asymmetry between the upper chest and abdomen. So we can label it as 2 score for the upper chest. Lower chest, as you can see that there is a lower intercostal retraction which is marked, and as well as the sigmoid retraction that is also marked. So that all becomes 8 by 10. Then we have to see the nasal dilatation, nearest dilatation. You can see that the nearest is marked dilatation is there. So this becomes a candidate for what? It's a respiratory failure. It's a candidate for intubation. Okay. So interpretation already told. SAS score of more than 3 in a preterm baby and SAS score of more than 5 in a term baby is an indication for CPAP. Along with that, Downey score is also there. Downey score also interpretation. Along with the, apart from the SAS score, respiratory rate is taken into account as well as oxygen requirement. Any baby on oxygen requirement, you have to take into account the how much oxygen is getting into the baby. Even though saturation looks normal, but if the baby's requirement of oxygen is more than 40, then it becomes a score of 2. So next comes the perfusion part. So perfusion, there is no single parameter is not there. In the sense that historically it is based, approach to cardiovascular support is based on the crude measures of the adequacy of pulmonary and systemic circulation. A singular approach based on mean arterial pressure alone is highly questionable, and many normative references are generally consensus based or based on expert opinion. There is no evidence regarding that. And traditional teaching focus is on maintaining the mean blood pressure or MAP, which is equal to gestational age. Example, for a 40-weeker, 40 will be the MAP. So there is, and other clinical parameters that we will take into account while looking at the cardiovascular status of a newborn is the heart rate. Any heart rate more than 160 is alarming. BP numbers, increased capillary refill time. Basically, if the CRT is more than 5 seconds, it is abnormal. Pallor or mottling of the skin. Then, as already mentioned, the level of consciousness and the end organ, that is the blood perfusing tissue such as renal, if there is a decreased urine output. Cellular level, tissue hypoxia manifested as elevated lactate or metabolic acidosis. So cardiac, there is no single parameter. You have to take and in the sense that heart rate along with NIBP, along with pulse volume, along with the peripherals, along with CRT should be taken into consideration. Single parameter is not useful for assessing the baby's cardiovascular status. You can see the capillary refill time. These are already I mentioned, the signs of shock. And also the most important regarding cardiovascular system is the saturation, SpO2. It should be done for each babies after 24 hours. And it is a danger sign if the saturation is less than 90% in either extremities, which is done at least 2 more times 1 hour apart, and the results is same. The sense that right upper limb saturation is less than 90% for 3 times 1 hour apart, then it is said to be a positive screen, and the baby should go for echocardiography. Or else, if the saturation is 90 to 94% in right hand and right foot, and the difference is more than 3% between right hand and right foot, and if you repeat it for 2 more times 1 hour apart, you are getting the same values, then also it's a positive screen and you should go for echocardiography. This is a danger sign in the baby. The most preventable cause of one of the danger signs is the hypoglycemia. The parameters that I have put is a 36-weeker, which is a late preterm, 38-weeker 2 kg SGA baby, 37-weeker 4.5 LGA baby, and a baby born to mother who is on insulin. So these babies should be monitored for sugar, should be monitored. IgDM or LGA baby should be monitored minimum 24 hours, and late preterm and SGA monitored minimum for 3 days, even though evidence says that up to 10 days these babies can develop low sugars. So this is one of the most preventable cause, and sugar should be monitored for these babies. Then comes jaundice. Jaundice, as you all know, jaundice in the first 24 hours. Any baby with any value of jaundice having neonatal encephalopathy is also a danger sign. Soul staining is also a danger sign. CNS, seizures, already mentioned regarding the sensorium. Seizures, any baby with seizures is also a danger sign. Metabolic part, hypoglycemia also already I dealt with. Sick babies, you should have ECG in the NICU so that hyperkalemia should not be missed. Extreme premature babies can manifest hyperkalemia as arrhythmias. Then another condition is CAH that can present as neonatal cardiac arrest. That means 2 weeks of life, baby presented with cardiac arrest. You should think of a CAH that can manifest as hyponatremia or hyperkalemia. Even hypocalcemia can present as seizures. Surgical conditions which can present as a newborn danger sign is persistent projectile bilious vomiting, which can be a malrotation or intestinal obstruction, blood in stool with abdomen distension and again vomiting, again intestinal obstruction, failure to pass meconium in 24 hours. You should look for anal opening, as anorectal malformations can be the diagnosis. Failure to pass urine in first 48 hours in a male baby, think of posterior urethral valve. Frothing from mouth but unable to pass the OGT, think of tracheoesophageal fistula. Cyanosis while baby is feeding but improves with cry. Spinal atresia, pale stools for high colored urine, think of biliary atresia. So this is the way we can approach a baby. So I am my bottom line is that look at the stops criteria. Anywhere, anytime, any days, you can look at the stops and you can identify the sickness level of the baby. And the WHO guidelines is that in position statement is that management of sick young infant up to 2 months. There's a participant manual as well as a facilitator manual. In these also they have taken into account all the above set parameters, such as is the infant having difficulty in feeding, respiratory rate they have taken, chest indrawing taken, temperature they have taken. Altogether stops will be coming, but in a structured way they have put. So this can also be taken. Along with that, look at the umbilicus and also skin pustules also they are taking into account. This is one of the case scenario they have put it in the facilitator participants manual. I have highlighted the important things: axillary temperature 36.5, not cried immediately, difficult breathing, not feeding well, 74 breaths per minute. So there is a IMC recording form is there. In this we can identify the possible severe bacterial infection or very severe disease. The baby is having jaundice or the baby is having diarrhea, HIV infection unlikely. This can also be used as a tool for identifying the sickness status or the danger signs in a baby. So at last slide is that danger signs include in nutshell sensorium, temperature, oxygenation, perfusion, and sugar. So this is the take-home message for the audience. Thank you.
Dr. Anand. Now we have come to the end of the session. Those who want to ask questions can raise their hand. I think Dr. Bennett can say a few words now.
Thank you all the speakers, and Dr. Anju for moderating the session, especially Dr. Anand, Hazeena, Radhika and Indumathy Madam and Dr. Kamala. Actually, this we are planning for the same session in every week. The main idea is to impart the knowledge of specialists to all the peripheral doctors. Peripheral means all the doctors who are practicing in the little facility places, so that our children, especially in COVID stage, the children will not get suffered because of the non-availability of the specialist or super specialist doctors. That is the main aim of this session. Thank you for sparing your whole time for this program, and thank you all the viewers for joining with us.
I think Bala sir is there. Bala sir, would you like to talk a few words?
Yeah. Thanks, Anand sir and Priya and IAP Thiruvananthapuram for again yet another interesting Zoom meeting. This one is topics are very interesting and useful to the pediatricians, general pediatricians especially. I hope, as Anand sir said, every week we will continue with interesting topics.
Okay, next week we are planning for this super specialist subjects like neurology, nephrology, like that, depending on the availability of the speakers.
Okay.
So there's a question. Cord bilirubin, what's the cutoff for starting ET on first day? Someone can answer. What is the cutoff for starting phototherapy on first day?
Phototherapy for I think it will be based on the charts on the gestation of the baby and what are the risk factors of the baby, and we are generally following the IAP bilirubin charts for babies more than 35 weeks. So we cannot say a single cutoff value. If the value is cord bilirubin value is more than 5, it is definitely alarming. But we will definitely look at other factors also. So you have to follow one chart, and the commonly used chart is the IAP chart for bilirubins.
I think anything above 2, Radhika, is to alert. Some people have to get alert. Check it out. Especially if they have
and you have to look at the gestation of the baby and the risk factors before deciding on.
So anything about 2 should sound everybody just to see what's happening. Yeah. After that, you can decide. Check again.
Questions? While using infrared thermometer and digital thermometer for recording temperature in children, should we add 1 degree?
No, I don't think we need to add 1 degree.
Lying down position for feeding can be followed.
I think that the mother is really tired. Sometimes they do allow. You preferably sitting down.
Madam, let me talk about position of the feeding, even though I am not a neonatologist, but as per the recommendation, I think in the year of 2005 or 2007, it is modified. There is no proper evidence saying that it will cause any problem for the ear. So at that time, a breastfeeding initiative, the advice is you can either give it by sitting or by lying posture. Whatever may be the position, both mother and child should be comfortable. That is the knowledge which I got. Please guide me more.
But we do see aspiration and ear infections more with lying position practically.
This is as per study. This is IAP protocol. I am talking the IAP recommendation from, I think it is from 2007 onwards.
When mothers ask for lying down, I don't think we can say no. Position is better always when they sit up and feed.
Madam, ഇത് പറഞ്ഞിട്ടുള്ളത് എവിഡൻസ് ബേസ്ഡ് ആയിട്ടാണ്. എവിഡൻസ് ബേസ്ഡ് എന്ന് പറയുമ്പോൾ സ്റ്റഡീസ് വെച്ചിട്ട് പ്രൂവ് ചെയ്യാണ്. എനിക്ക് ബുക്ക് വരെ കോട്ട് ചെയ്യാൻ പറ്റും. ബുക്ക് എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ റെക്കമെൻഡഡ് ബൈ IAP.
Sir, rightly pointed out,
Sir.
there is lying down position is also there. I think if mother and baby is comfortable, lying down position can also be favored. There is no harm in giving breast milk by lying down position.
Okay. Okay. Thank
One
you.
question to Dr. Hazeena. L-Rutri for colic, your experience.
Can I add to that?
Yeah, please.
Sorry. Madam, continue, madam.
No, I haven't. Personally, I have no experience. I have just read about it, and some people have come to me and talked about it, but I have been given to any baby, so I don't have any personal experience.
Dr. Anand, you can add on.
Madam, I have no experience regarding that, but the evidence says that if you give L-Rutri for colic, the duration you give the medicine, and the normal course of the disease, or what you say, that infant colic, it's same. And it's same. And the thing is, the cost you are adding to that for giving this drug is huge.
Cost is huge. That is why I didn't prefer to start.
Correct.
Cost is huge compared to
it is not, and it may not be easy to come by. I think it is available online, but routine stores are not. What is recommended, that it is not easily available. And studies have shown a marginal decrease in the crying time. That is all. Not much. As Anand has said, the final effect, there is not much difference. But probably for the parents, it is a placebo. They feel they have given some medicine to the baby, and that is mainly that. I don't think it is a magic medicine. Colic will take its time and it will go on its own. So it's not a magic medicine, but for some studies have shown that some crying time is reduced by giving these probiotics.
Yes, Radhika, I also agree with that.
Anju?
Yeah. Any more questions? If there are no more questions, I think we can end the session. I would like to thank all the speakers who have participated and all the participants.